Welcome everyone to today's session. We are going to start in a few minutes. I'm going to let people enter the webinar. In the meanwhile, please feel free to introduce yourself in the chat. Let us know who you are and where you're joining us from. We will start in another minute or so. Thank you. Okay, super. Welcome, everybody. Good morning, good afternoon, good evening. Welcome to today's launch of the new WHO guideline on preventing early pregnancy and poor reproductive health outcomes for adolescents in low and middle income countries. We are delighted to have so many of you with us today. My name is Nandita Thate. I am a technical officer in the Department of Sexual and Reproductive Health and Research, including the Special Programme HRP, where I lead the IBP Network, a consortium of civil society partners working to disseminate and use evidence-based guidelines in reproductive health, sexual and reproductive health. And we are delighted to be co-hosting this event with you today. I'm going to go over some quick housekeeping and then we will get started. Please note that the webinar today will be recorded. We also have interpretation into French and Spanish. You can select your language of choice at the bottom of your screen. And we've kept the chat open as well as the Q&A box so you can have a discussion, submit your questions. We will try to answer them in real time in the chat and in the Q&A box as best as we can. And finally, the webinar will be recorded and posted on the WHO HRP Media YouTube channel, so you can watch the video later on. Today's agenda is very exciting and also very full. We're going to start with some opening remarks. We'll then have a little background and context about the guideline. We'll go through the guideline, some key messages and key points, and then we will have two panel discussions on really what this guideline means for countries and for implementers around the world. Finally, we'll have some closing remarks. So with that, I am going to turn it over to a video from the Director of the Department of Sexual and Reproductive Health and Research, Dr. Pascale Allotey. She has recorded a statement that I'm going to play now.
Colleagues, it is both a privilege and a profound responsibility to launch the World Health Organization's updated guideline on preventing early pregnancy and poor reproductive outcomes among adolescents in low and middle income countries. This is not a guideline, it is a lifeline. Adolescent pregnancy remains one of the most urgent and yet preventable public health challenges of our time. Every year, millions of girls, many still children themselves, become mothers too soon. For girls aged 15 to 19, complications during pregnancy and childbirth are the leading cause of death. Those who survive are too often forced to trade in their education, their aspirations, and sometimes their autonomy simply for having gone through a natural transition without support. We are failing our young people. This is the consequence of silence, stigma, and structural neglect. Girls who marry before 18 are more likely to experience early and repeated pregnancies. They are more likely to drop out of school, more likely to suffer poor mental health, and less likely to reach their full potential. And while child marriage compounds risk, adolescent girls everywhere, married or not, often lack access to the information, the tools, and the respect they need to make empowered decisions about their health and lives. But here is what we also know. These outcomes are not inevitable. They are preventable. And WHO is once again stepping forward with the evidence, the clarity, and the commitment needed to support countries in protecting empowering, and investing in the next generation. The updated guideline builds on a decade of experience and progress since its initial release in 2011. It is grounded in robust science and lived realities. It recognizes that the world has changed, and so must our response. Central to this guidance is comprehensive sexuality education, not as a luxury, but as a right, not as a threat, but as a tool for resilience and dignity. When coupled with adolescent-friendly health services, enabling laws and policies, and supportive community environments, we can create ecosystems that support both agency and protection. And because this is the balance we must strike, ensuring that all adolescents, especially girls, have the power to make informed decisions while also shielding them from the harms they should never be made to bear. We can't afford to be complacent. In today's landscape of shrinking civil space and rising resistance to sexual and reproductive health and rights, the stakes are higher than ever. We have to speak clearly, act boldly, and stand in solidarity, especially with the most vulnerable. Out-of-school girls, those in humanitarian settings, those living with HIV, survivors of violence, and marginalized youth. The recommendations in this guideline are not abstract. They are actionable, they are achievable, and they are urgently needed. So let's use them to spark some new commitments. Let's use them to challenge complacency and push back against regression. Let's use them to foster a world where every adolescent has the tools to shape their future and not just survive it. This is not only a matter of public health, it is a matter of justice. Thank you. Colleagues.
Super. Thank you so much, Pascale. I know she wishes she could be here live with all of us, but she sends her best, and we are thankful for her inspiring remarks. It is now my pleasure to introduce Dr. Julia Bunting. She is the Program Division Director at UNFPA, spanning a long career in sexual and reproductive health and rights. Previously, she was the CEO and Executive Director of the Population Council and is a true champion for sexual and reproductive health and particularly for adolescents in this space. So thank you, Julia. Welcome. You have the floor.
Thank you so much, Nindita. Honourable government officials, colleagues, friends and champions for adolescent sexual and reproductive health and rights. Good morning, good afternoon, good evening. On behalf of the United Nations Population Fund, UNFPA, it's a pleasure to be here as one of the co-sponsors of the Human Reproductive Programme at WHO. Today marks an important milestone for the SRHR movement as we launch updated WHO guidelines entitled Preventing Early Pregnancy and Poor Reproductive Outcomes Among Adolescents in Low and Middle Income Countries. Your presence here today is testament to your commitment to safeguarding the sexual and reproductive health and rights of adolescents and adolescent girls in particular. We all know the data only too well. Globally, an estimated 21 million pregnancies occur each year among adolescent girls aged 15 to 19 in lower middle income countries, and half of those pregnancies are unintended. And each year, approximately 12 million adolescent girls are married in childhood. The latest analysis, data from 54 developing countries where data is available, the latest analysis shows that the majority of first births to girls aged 17 years and younger occur within marriage or within cohabiting unions. And while adolescent pregnancies also occur in high-income countries, they are most predominant in lower middle-income countries. Sub-Saharan Africa and Latin America are the regions that continue to have the highest rates, and we know that girls with little or no access to education and resources are the most at risk. Addressing these needs will require commitment and concerted efforts, which is why these guidelines being launched today are so important to us all. They provide us, as Pascale said, with an evidence-based roadmap to support policymakers, programmers and practitioners to accelerate progress by increasing access to, uptake of, and continued use of contraception among adolescents, for example, by preventing child marriage and responding to the needs and rights of married girls. UNFPA is an agency that centres its work on promoting the rights of all adolescents and young people, focuses on gender equality and ensuring that everyone has universal access to sexual and reproductive health, is pleased to have provided technical and financial support to the development of these guidelines. And I also want to recognise our partnership with the Population Council, which was particularly instrumental in contributing to the evidence base on child marriage. UNFPA is committed to promoting the implementation of these important guidelines, especially through flagship programmes such as the UNFPA UNICEF Global Programme to End Child Marriage and the joint UN programme Together for SRHR in East and Southern Africa. As we at UNFPA develop our next strategic plan, we know that unless we centre the needs of adolescents and young people, we will not get very far on realising the vision of the ICBD Programme of Action. We need young people as partners, designing and developing programmes, and as leaders and activists holding the rest of us accountable. To conclude, and as Pascale said in her opening comment, in times of addressing pushback, let's push forward together for evidence-based interventions at scale. The guidelines can be an important part of that roadmap and that compass. Thank you again to WHO and all the partners for convening us today and for all of you who've joined us for this important launch event.
Wonderful. Thank you so much, Julia, for your inspiring remarks and the support from UNFPA and the many partners. It is now my privilege to introduce our next speaker, Dr. Venkatraman Chandra-Mouli. Many of us know him well. With over 30 years at WHO, Chandra has not only shaped global adolescent sexual and reproductive health research and policy, but also mentored many of us, including me, along the way. A lifelong learner, tireless champion, and a guiding force in our field, we're deeply honored to have you with us here today, Chandra. Welcome. You have the floor. Chandra?
Thank you, Nandita. Namaste. 5 years, could I have my next slide, please? 5 years before the Sustainable Development Goals target date, where are we in the world with adolescent pregnancy and childbearing? I'm going to make 5 points to frame the discussion in this launch webinar. The next slide, please. The Girls' Goals Report, a wonderful piece of work published this year by UNICEF, UN Women, and Plan International, notes that adolescent birth rate has nearly halved over the last 30 years, from 73 to 38 per 1,000 girls aged 15 to 19, as you can see on this slide. The decline in birth rates in 10 to 14-year-old girls has been even sharper, again, as you can see on this slide. I'd like to make 3 other points. Firstly, the Girls' Goals Report notes that the reduction in the levels of child marriage globally and the increase in the uptake of contraception have contributed to this decline. Secondly, the global average figures mask regional differences, as you can see in this slide. And while there's been a decline in all world regions, there are differences between regions, between countries in each region, between districts in each country, and even within communities in each district. So while there's been progress, progress has been uneven. And thirdly, despite this decline, as Julia Bunting rightly noted, 12 million girls aged 15 to 19 and 325,000 girls aged 10 to 14 are expected to give birth this year. So progress, uneven progress, and unfinished business. Next slide, please. Moving closer to the ground, we can see who's being left behind. Again, to reinforce what Julia said and what Pascale said, girls and young women with low levels of education, in poor families, living in remote rural areas, and deprived urban areas, and those in situations of conflict and climate crises. So one of the SDG mantras is not to leave anyone behind. And what we can see is while we have made progress in reducing adolescent pregnancies and childbirths, we are leaving the most vulnerable girls and their families behind. Next slide, please. 30 years ago, the International Conference on Population and Development placed adolescent pregnancy and childbearing and adolescent sexual and reproductive health more generally on the global health, development, and human rights agendas. On the screen in small letters, you'll see the language used in the ICPD Plan of Action. And you can see 30 years ago, the world had a nuanced understanding of adolescent pregnancy and childbearing, of its causes and consequences. What they didn't have then was evidence on effective approaches to prevent adolescent pregnancy and childbearing and respond to the needs of pregnant and parenting adolescents. That's where the WHO guideline, the updated WHO guideline, comes in. Adolescent pregnancy was on the agenda of the Millennium Development Goals, but because there were other priorities such as child survival and then maternal mortality reduction, it did not get the attention it deserved. But in the Sustainable Development Goals, it is at the heart of the agenda. It's also at the heart of regional agendas, such as those of the African Union and the South Asian Association for Regional Cooperation. The next slide. Adolescent pregnancy is high on national agendas as well. In the past, it was NGOs doing this work. Now, governments are leading this work. In this just published book, we have documented success stories from national government-led adolescent pregnancy programs. One outstanding example is that of Thailand, as you can see on the screen. In Thailand, rates of adolescent childbearing increased substantially during the 2000s. The government decided to act. After careful reflection and discussion, they passed the Act for Prevention and Solution of Adolescent Pregnancy. They executed the act with the oversight of the Prime Minister's office, and within a decade, there was substantial progress. There's unfinished business in Thailand too, just like everywhere, but progress is possible. Thailand and the other countries show that with bold leadership, good science, and effective management, success is possible in different contexts in reducing adolescent pregnancy and childbearing. My last slide. Over the last 30 years, low and middle income countries around the world have made enormous progress in the areas that they're focused on: child marriage, female genital mutilation, HIV, and adolescent pregnancy. There's unfinished business in each of these areas. There's also a huge amount of work to be done outside these areas. Within SRHR, for example, in reducing intimate partner violence and sexual violence, and outside SRHR, such as in addressing depression and anxiety. We are shocked and saddened by what is happening in the world today. A world that is hard to recognize or even believe. But we cannot afford to be paralyzed. We must get up, regroup, and move ahead on three fronts. We must build on the progress made and build on a learning, which is what the WHO guideline does. We must counteract attacks to SRHR effectively. And we must join forces as one to advance adolescent health, but also social justice and the autonomy and the leadership of the Global South. Thank you and namaste. And now it's my real privilege to pass the baton to Sheri Bastien, who works as a scientist on adolescent sexual and reproductive health at WHO's Department of Sexual and Reproductive Health and Rights, which also hosts the co-sponsored Human Reproduction Program. Over to you, Sheri, and congratulations for taking this important piece of work to the finishing line.
Thank you so much for that introduction, Chandra, and for your inspiring remarks and your mentorship and support. It means the world. Good morning, good afternoon, or good evening, colleagues from WHO headquarters in Geneva. It is a real pleasure to be here today to provide an overview of the guideline on behalf of all of the contributors. As a bit of background to get us started, in 2011, WHO published the first guideline on preventing early pregnancy and poor reproductive outcomes among adolescents, and we have now updated it at the request of stakeholders both within and outside the UN system. For me personally, it was an honor and a steep learning curve to step into the Guideline Development Group convenings in 2023, and a real privilege to contribute to the team effort involved in taking this guideline across the finish line. In terms of the global context, I won't spend time on this, as Chandra has laid this out well in his presentation. My point of departure and aim today will be to provide a very brief orientation to the guideline to set the stage for the rich panel discussions to follow. So on this slide, you can see the covers of the 2011 and 2025 guidelines, both of which provide evidence-based normative guidance on interventions to reduce early pregnancy and its resulting poor reproductive outcomes. The rationale for the update was twofold. Additional research evidence and programmatic experience had been generated, including in areas where there was previously limited or no evidence eligible for grading. Secondly, the field has transitioned from a focus on addressing the needs of all adolescents to addressing the needs of specific groups that are consistently left behind. Next slide, please. I will now touch briefly on the similarities and differences between the 2011 and the updated guideline. In terms of the rationale, this was largely similar for the reasons mentioned in my last slide. With respect to the objectives, these remain unchanged. Next slide, please. In terms of scope, the scope of the current guideline is reduced. This is because separate technical guidelines and guidance have been developed on 4 of the 6 outcomes included in the 2011 edition. Therefore, this update focuses on the remaining 2 objectives. Firstly, preventing child marriage, and secondly, improving access to, uptake of, and continued use of contraception among adolescents. The intended audience remains unchanged. We anticipate that the guideline will be useful for a wide range of stakeholders working within adolescent sexual and reproductive health, and specifically for the target groups mentioned on the slide. Next, please. The guideline development process was largely similar in that both were developed according to WHO standards and requirements. Oversight was provided by the WHO Guidelines Review Committee. Key decisions were made by a Guideline Development Group, the GDG, which consisted of global experts with a tremendous depth of technical expertise and passion for the topic, including 2 evidence teams, one on child marriage and another on adolescent contraception, and with decisions facilitated by a guideline methodologist and based on, at times, lively and very engaged discussions that took place during 4 convenings of the GDG. Evidence was evaluated using the grading of recommendations, assessment, development, and evaluation approach. And as a bit of background, when formulating recommendations and good practice statements, it isn't only the quality of the evidence that gets taken into consideration. There are other important factors that come into play, including the balance of benefits to harms, values and preferences, acceptability, feasibility, resource requirements, equity, and other factors. The main takeaway here is that guideline development is a highly systematic process that brings together the best available evidence alongside country experience. There are, however, a few notable changes I would like to flag. Firstly, the inclusion of country teams with a youth representative from each WHO region on the external review group in the current guideline. There were country teams from Argentina, Bangladesh, Burkina Faso, the Republic of Moldova, the Philippines, and Yemen, highlighting the wide geographic representation in the consultations and process. The second point relates to the inclusion of good practice statements in the current guideline, which in terms of implementation should be viewed as equivalent to strong recommendations. In other words, they are recommended for all or almost all populations and contexts. Next slide, please. In the figure on this slide, you can see an overview of the recommendations and good practice statements in the guideline. The purpose of showing this slide is simply to highlight that the recommendations and good practice statements cut across different levels of the social ecological framework, from the individual level and across other levels to reaching the policy and societal levels. This, of course, draws attention to the need for multi-level, multi-sectoral approaches. In the next few slides, I will provide a high-level overview of the recommendations and good practice statements. In the interest of time, I won't read through the lists in full, but I will describe one recommendation and good practice statement in each set in greater depth to give you some insight into the evidence and context behind the decision-making and discussions that took place among the GDG members. Next slide, please. Here you can see the full list of recommendations related to preventing child marriage. In brief, as you can see, the recommendations here focus on the importance of interventions to empower girls by building their knowledge, skills, assets, and social networks, engaging parents and guardians, boys and men, as well as the broader community to sustain a gender equitable and enabling environment. Thirdly, offering conditional incentives to increase educational attainment. Fourthly, highlighting the importance of interventions to remove gender-related barriers to education, and additionally, the recommendation to implement interventions aimed at economic empowerment of girls. Finally, there is a recommendation related to laws that restrict marriage before age 18. Next slide, please. I just want to take a moment to hone in on a few details related to recommendation 1.5, which I know is of particular interest to the adolescent sexual and reproductive health community. In terms of the evidence base, 11 studies from 11 interventions, including 6 randomized controlled trials and 3 quasi-experimental studies, in addition to 3 observational studies, were included in the analysis. The rationale behind this particular recommendation is that strategies such as vocational training, life skills development, mentoring, and access to job opportunities show promise in increasing girls' autonomy, expanding alternatives to early marriage, and ultimately improving future prospects. Next slide, please. I will now turn to the good practice statements that were issued in relation to preventing child marriage. This set of 3 good practice statements focuses on the importance of mobilizing political, governmental, traditional, and other influential leaders, ensuring that efforts to address the specific needs and rights of ever-married girls and those in formal or informal unions, and the importance of meaningfully engaging adolescents in all efforts to address their needs and rights. Next slide, please. So let us take a closer look at Good Practice Statement 1.2. The analysis here was based on 6 studies from 6 interventions, including 2 randomized controlled trials and 4 quasi-experimental studies. The rationale for this good practice statement is that despite awareness of the harmful consequences of child marriage, married girls are often overlooked in policies and programs. This highlights the importance of moving away from cookie-cutter, one-size-fits-all approaches towards tailored interventions. Next slide, please. On this slide, you can see the full set of recommendations related to improving access to, uptake of, and continued use of contraception. As you can see, these relate to the need for gender transformative behavior change interventions to support adolescent decision-making around contraceptive use, interventions to shift gender and other social norms. There is also a subset of recommendations that were carried forward from WHO's guideline on self-care interventions for health and well-being, in addition to recommendations related to interventions to reduce financial barriers, as well as accurate and safe digital health interventions. So as you can see, there's really a broad range of issues covered by this set of recommendations. Now let's zoom in on one in particular. Next slide, please. Recommendation 2.4 is a timely and highly relevant recommendation to take a closer look at, given the increasing prominence in the digital space within adolescent sexual and reproductive health. With respect to the evidence, 4 studies from 4 interventions, including 3 randomized controlled trials and 1 observational study, were included in the analysis. The rationale here is that digital health interventions have tremendous potential to expand patient autonomy, but also the reach of health services. However, they must be carefully designed to mitigate risks such as misinformation, privacy violations, and the potential to exacerbate inequity. Next slide, please. I will now turn to the good practice statements related to adolescent contraception. As you can see, these relate to the importance of mobilizing political, governmental, religious, traditional, and other influential leaders, the need for interventions to improve the quality of health services, ensuring that enabling laws and policies on age, marital status, and consent are in place, alongside access to services and contraceptive methods, and as with child marriage, an emphasis on the importance of meaningfully engaging adolescents in efforts that address their contraceptive needs and rights. Next slide, please. Just to elaborate briefly on Good Practice Statement 2.2, which relates to a hugely important issue, quality of health services. The analysis of the evidence here included 8 studies from 8 interventions, including 1 randomized controlled trial and 7 observational studies. The rationale being that across contexts, adolescent services are very often fragmented, poorly coordinated, and inconsistent in quality. And if we really want to ensure high quality service provision, it requires delivering contraceptive information and care in ways that respects adolescents' needs, their right to dignity, autonomy, privacy, and confidentiality. I hope these in-depth snapshots illustrate the level of detail behind every single recommendation and good practice statement in the guideline. Next slide, please. I would like to briefly mention that the second objective of the guideline was to provide an analytical framework for policymakers and program managers to use when selecting evidence-based interventions that meet the needs of countries and their contexts. This is absolutely crucial because we want the guideline to be used by countries to strengthen their programs and policies. In 2023, WHO, in partnership with several other UN agencies, published the 2nd edition of the Global Accelerated Action for the Health of Adolescents, Guidance to Support Country Implementation, also known as AHA 2.0. This important guidance sets out a useful step-by-step process for responding to this need, which you can see on the slide. Specifically, this section of the guideline aims to provide a starting point to guide readers in the process of firstly, setting priorities, secondly, selecting interventions with the help of established frameworks, such as the one mentioned here from Population Council and the International Center for Research on Women. Third, striking a balance between global goals and local needs, including an explicit focus on leaving no one behind. And finally, ensuring that robust monitoring and evaluation of programs is conducted to ensure effectiveness and sustainability over time. Next slide, please. I would like to turn now to next steps for rolling out the guideline, and I would like to start off by saying that this is not just a WHO guideline. It was developed by and belongs to the entire community, and so a joint effort is really needed to ensure this guideline isn't collecting dust on a shelf or the digital equivalent. We really hope to engage all of you in the dissemination and uptake of this guideline, so please do reach out to us to discuss this. Otherwise, as mentioned here, we will use a wide range of approaches to socialize the guideline through traditional and social media, journal articles, webinars, and conferences. Secondly, capacity will be built for the regional and national adaptation and application of the guideline through various means, with a strong focus on multi-sectoral efforts. Third, we will work to support countries through partnerships with other UN agencies and with organizations such as Girls Not Brides, FP2030, MSI, and others. The next action item relates to a focus on supporting efforts to generate evidence on key research gaps, including through 2 parallel research priority setting exercises that have been undertaken in the last year. And finally, with respect to plans for future guideline updates, this will be done based on an assessment of its need and will of course adhere to WHO standards and possibly adopting a living guideline approach. Next slide, please. I would like to close off by acknowledging the substantive contributions to the guideline development by so many technical experts, including members of the Guideline Steering Group, the GDG, the External Review Group, the co-chairs, the evidence teams, our guideline methodologists, the observers, and representatives of UN agencies who really contributed vastly to this process. I would also like to acknowledge with gratitude the funding for the development of the guideline, which was provided by the organizations mentioned on this slide. And with that, I would now like to hand back to Chandra to introduce the esteemed speakers we are delighted to have with us for the high-level panel. Chandra, over to you.
Bravo, Sheri. That was a stellar presentation. Thank you very much. Following Sheri's presentation, we will shift to the discussion section. We are running slightly over time, and so we're going to shorten this 30-minute segment to 25 minutes. In this segment, we'll have 4 people from different contexts, different disciplines, and different work experiences. Sit back and enjoy. This is going to be fun. I'm not going to read out their bios. You can see this on the screen. I'd like to start with you, Stevie. Ms. Stevie Reine Yameogo was a member of the Guidelines Development Group. Stevie is from Burkina Faso. She's a sociologist, an activist, a social justice and gender equality advocate. She co-founded and leads an organization, a youth-led organization that is working to engage and mobilize communities and bring about change. Stevie, in 1 or 2 sentences, what was your perspective of contributing to the development of the guideline that we are launching today? Thank you. Stevie will speak in French, and you can get the English translation or the Spanish translation if you want. Merci, Stevie.
Okay.
Vas-y, s'il vous plaît.
Chandra, pour la question. Je pense que sur la ligne directrice, elle a été une expérience profondément transformatrice, exigeante et en même temps enrichissante. Parce qu'en tant que sociologue et militante de terrain, j'ai pu contribuer à faire remonter des réalités de vécues par les adolescents au niveau du Burkina et aussi en Afrique de l'Ouest, tout en travaillant bien sûr en étroite collaboration avec d'autres membres qui sont issus du ministère de la Santé et qui ont montré un réel ouverture à intégrer des perspectives jeunes. Et cette démarche collective m'a aussi permis de renforcer un dialogue intergénérationnel, mais aussi interinstitutionnel entre les jeunes, mais aussi les décideurs et les experts. Et je tiens véritablement à saluer la qualité de l'écoute et du respect mutuel qui ont marqué nos échanges avec l'équipe de l'OMS, notamment avec toi, Chandra, dont l'engagement pour une approche inclusive m'a beaucoup inspiré. Et je pense que nous avons veillé à ce que ces lignes-là ne restent pas seulement un document technique, mais que ça puisse devenir un outil stratégique pour transformer le système de santé et surtout garantir les droits en santé sexuelle et reproductive des adolescents et jeunes. Donc, voilà un peu ce que je peux dire sur cette question. Merci.
Merci, Stevie. Now, from the perspective of someone who's been intimately involved in the youth movement in Burkina Faso, what progress has been made in adolescent pregnancy, both in preventing pregnancy and responding to pregnant and parenting adolescents and child brides, and what progress needs to be made? Again, Stevie, I'm sorry, but I have to press you to be very brief.
Alors, beaucoup de progrès qui restent quand même inégaux parce que nous avons assisté à plusieurs avancées structurantes ces dernières années. On a une volonté manifeste des politiques à travers l'adoption de politiques nationales multisectorielles de santé et adolescents. Sur le terrain aussi, on a les acteurs communautaires qui interagissent justement à travers des actions de prévention via des clubs de jeunes, des centres d'écoute et même des cliniques. Toutefois, malgré ces efforts, il y a aussi justement des difficultés qui font que la question de mariage d'enfants reste encore un sujet d'actualité. Par exemple, au niveau du Burkina, on a plus de 52% de filles qui restent toujours, qui sont mariées avant l'âge de 18 ans. Donc, ces chiffres viennent témoigner justement un décalage inquiétant entre les politiques et leur mise en œuvre réelle. Et en même temps, ça nous interpelle justement à mieux utiliser ces lignes directrices-là pour pouvoir justement actionner davantage et avoir des résultats probants. Merci.
Thank you, Stevie. I think you've answered my third question, which is, what is the place of adolescent pregnancy in the movements and organizations you're part of? And I think what you've said is this is high on the agenda. The guidelines will be useful for you. Any quick last word on this before I move to the next speaker?
Alors, merci. Ce que je voulais dire, c'est que on puisse en tout cas véritablement utiliser ces lignes directrices et donc j'appelle à l'action toutes les parties prenantes de tous les pays parce que l'objectif est de traduire les normes mondiales comme celles de l'OMS en actions concrètes ancrées dans les réalités locales et c'est important justement de ne pas faire fi de ce document référentiel et j'invite tout le monde à l'utiliser à bon escient. Merci.
Merci, mon ami. Merci beaucoup pour vos réponses claires. Thank you very much. Let me move from Stevie to Dr. Ron Allan C, who is a medical officer in the Philippine government's Department of Health. Could we see you, please, Ron Allan? He leads the Adolescent Health and Development Program in the Division of Child, Adolescent, and Maternal Health. Ron Allan brings to his work experience a long track record as a community doctor, as a professor in medical school, as an administrator in the School of Public Health, but he also brings passion to this work that began with his work in youth health and adolescent health as a college student. Welcome, Ron Allan. Great to see you. We worked together in Nepal in September. Lovely to see you in this platform. So the same questions to you. From your perspective, from all these perspectives you have, but now in an important position in the Ministry of Health of your country, what progress has been made or not made in adolescent pregnancy and responding to pregnant and parenting adolescents? Again, Ron Allan, terribly sorry, but you'll need to be brief.
Thank you. Thank you, Chandra. Actually, the general trend of adolescent pregnancy cases among our 15 years old is decreasing since 2019, as reported in our Statistics Authority. And the same is also true for our NDHS in the 2013, 2017, 2022. But what is alarming is our 10 to 14 years old. Since 2020, it was increasing. And the total maternal deaths among our adolescents is still high for us at 150. And for child early forced marriage and unions, 1 out of 6 Filipino girls are married before they are 19 years old. That's why the executive order 141, which was released in 2021, is still relevant, since we need to further strengthen what is in our comprehensive action plan of 2025 to 2028 towards the prevention of unintended adolescent pregnancy. And likewise, the government of the Philippines already created the Committee in Preventing Child Early and Forced Marriage and Unions that is currently drafting the National Action Plan. But of course, these separate action plans need more alignment so that the government agencies will have more efficiency. Thank you.
Thank you, Ron Allan. 2 quick questions. Why do you believe the pregnancy rates in the 10 to 14 years age group are rising? That's one question. And another question is, could you share with us 500 plus people in this panel something that you're really proud of in terms of what Philippines has done in the last 1 year or so?
Yeah, I think it was found out that in other government agencies, although we raised already the age of statutory rape from 12 to 16, which aims to protect children from sexual abuse and exploitation, we found out that there's still gender inequality and power imbalances because only 97% of all live births within the 10 to 14 age group had been fathered by men who are older than them, and only 3% had been fathered by teenage boys. But I think what we've been doing right now is constant coordination with other government agencies, since I also represent our chief ministers in the interagency technical working group in the prevention of unintended adolescent pregnancies. And of course, the RA on the act prohibiting the practice of child marriage was already in place.
Thank you, Ron Allan. I think what you've done is touched on a very important issue. Like several speakers, Pascale, Julia, and others have said, we need sexuality education. We need to end child marriage. We need contraception. But we have to address intimate partner violence and sexual abuse. And this, of course, like you rightly say, is about power and about impunity and about doing things and getting away with it. And it's wonderful to see your commitment to the whole range of actions. Bravo. Any last word from you before I move to the next speaker?
Rest assured that the Department of Health will look closely into this once more. Congratulations for the guidelines, the updated guidelines. And of course, it is our hope that we will be able to effectively mobilize our regions in the Philippines in the certification of adolescent-friendly health facilities, both in the primary care facility and public hospitals, coupled by capacity building on adolescent job aid, skills enhancement training. And we hope that WHO will give us technical support by giving our chief or secretary of health and undersecretaries the opportunity to learn from other countries in Southeast Asia who are doing better than us in terms of adolescent birth rate. And we also look forward for a more granular support from the WHO country office, such as the expansion of JPARAP to include digital health interventions here in the Philippines. Thank you very much.
Thank you, Ron Allan. You need to have a call with Sheri on this. Thank you very much. I'm going to take the point that Ron Allan raised about sexual abuse and move to the next speaker. Honorable Aboubekrine El Jera is from Mauritania. He's an adjunct professor in the law faculty in the University of Nouakchott and is a member of the Africa Committee for Experts on the Rights and Welfare of the Child. So he brings to this discussion his track record of work to promote and protect girls' and women's rights, with a particular focus on those who are marginalized and those who have experienced gender-based violence. So over to you, Aboubekrine. From your perspective as a lawyer and as a human rights champion, what is your reading on the situation, the progress made, progress yet to be made? And again, I'm sorry, you will need to be brief. Are you there, Aboubekrine? Please, go ahead.
Je suis là, docteur Chandra. Vous m'entendez?
Vas-y, s'il vous plaît. Est-ce que vous avez entendu la question que j'ai posée?
Oui, je les ai entendus.
Okay.
D'emblée, je dirais la situation des adolescentes en Afrique demeure contrastée sur le plan de la reconnaissance de droits que c'est celui de la mise en œuvre effective. À cet égard, malgré l'adoption des cadres normatifs et juridiques au niveau régional et national et les mesures pratiques prises dans plusieurs États, de nombreux défis persistent pour garantir pleinement la réalisation de leurs droits en santé de reproduction et droits reproductifs. D'une part, il y a des avancées notables qui sont observées dans plusieurs pays en matière d'accès aux soins de santé primaire et à la reconnaissance progressive de droits. D'autre part, de nombreux adolescentes continuent de faire face à des défis majeurs, notamment un accès inégal aux services de santé et l'absence des mécanismes et des mesures adaptés à leurs besoins en matière de santé mentale et reproductive, à l'absence de ressources adéquates. De plus, la pauvreté, la stigmatisation, les tabous et les pratiques socioculturelles alimentent les inégalités existantes, en particulier dans les zones reculées, surtout en zone rurale et parmi les groupes les plus vulnérables, empêchant l'accès aux droits ou aux services et accentuant les disparités et les inégalités. Cette situation est d'autant plus préoccupante pour les adolescentes en situation d'handicap qui nécessitent la prise en charge et mise en œuvre effective des mesures nécessaires pour répondre à l'inaccessibilité aux infrastructures sanitaires, le manque de services adaptés et l'adoption des financements et des politiques inclusives. Donc, ceci dit en un mot, vraiment la santé des adolescents pose problème et c'est les directives aujourd'hui que nous avance l'OMS en 2025, et surtout pour les pays intermédiaires, est une nécessité capitale que vous avez introduit de façon très efficace. Aujourd'hui, voici la situation dont je vous donne de façon succincte pour le moment, M. Dr Chandra.
Merci, mon ami. So I think Aboubekrine has stressed the need to address adolescents who are most marginalized and address settings where the resources around them are the least capable to respond to their needs and meet their rights. There's much to be done, and as Sheri said, one of the big focuses of this guideline and the work moving forward is inequity, addressing inequity. Thank you, Aboubekrine. We move to the last panelist now. Ms. Sophie Hodder is the Director of Girl Capital Africa, the Girl Capital Africa initiative at the Children's Investment Fund Foundation. Sophie's multi-sectoral portfolio works to ensure... Attendez, Monsieur Aboubekrine, on va revenir sur vous. So Sophie's multi-sectoral portfolio works to ensure that girls have the resources, the agency, and the opportunities they need to thrive in communities and countries that they are part of. She has 2 decades of work with girls and women across Africa and a strong commitment to their well-being. So Sophie, from your perspective in SIF and from your years of work in several countries of sub-Saharan Africa, what's your reading of the question that I've already posed? Thank you, and over to you.
Thank you, Chandra. So let me begin by acknowledging the tremendous advocacy, research, and implementation efforts that have helped move the needle on access to sexual and reproductive health, ending child pregnancy and child marriage globally. And thank you for WHO's leadership. What we need today more than ever is evidence-based guidance on what works to help us work at pace and scale. We've seen real progress in some of the regions around the world, particularly on child marriage, which is a leading but of course not the only cause of child pregnancy. Yet in Africa, where I'm leading the portfolio on ending violence to girls, child pregnancy and child marriage, 1 in 3 girls is married before 18 and 1 in 10 before the age of 15. And progress has been very uneven. Each year, 4 million African girls are still married before the age of 18. The health and human consequences are enormous. As we are all aware, the impact surrounding child marriage and child pregnancy is far-reaching. Children giving birth to children are more likely to suffer complications in pregnancy and childbirth, a leading cause of death for girls between the ages of 15 and 19. They're also more likely to drop out of school, face intimate partner violence, and suffer social isolation. These girls often face not only early motherhood, but also repeat pregnancies without access to quality sexual and reproductive health services. Here at SIF, we're committed to changing this and want to do this holistically, with the girl at the centre of everything that we're supporting. By way of an example, in Kenya, with our partnership with Government of Kenya Pop Council, we're supporting the use of cash transfers and mentoring to delay child marriage and pregnancy by keeping girls or returning girls into school, improving girls' economic security and their agency. But the unfinished business is still significant. Africa still has over 60 million girls out of school. Without education, girls are more vulnerable to child marriage, early pregnancy, and lifelong poverty. We need sustained, multi-sectorial action to transform the systems that enable these harms, and that includes a fully integrated education, SRH services, protection, and livelihood support in how we work with girls.
Thank you, Sophie. You've captured the issue very, very clearly and very powerfully. There's been progress globally. Parts of the world have been left behind. Sub-Saharan Africa is one of them. And within Sub-Saharan Africa, there are countries which have made progress, but there are countries which are so far behind. And a lot has to be done. And in this climate where many governments have withdrawn resources, we have to pool whatever resources and energy is available to do the best that we can. A parting word from you, Sophie, in 15 seconds before I pass on the baton to the next speaker.
Absolutely. I guess my parting word would be that at SIF we're calling on governments to continue to show leadership by enforcing minimum marriage age laws. We also call on governments, donors, governments, philanthropists to invest in SRHR services and commodities, in education, in creating meaningful alternatives to marriage, like in employment opportunities, skilling and safe spaces. At this current pace, we're not going to achieve gender equity until the 22nd century, which is unacceptable. So we must act faster and we must act together.
We must act faster. We must work together. Thank you, Sophie. And with that, I'm going to thank my 4 panelists. We had hoped to have another round of discussion, but I don't want to eat into the next speaker's time, next panel's time. So I'm going to pass on the baton to Iman Lakbachi. She's from Morocco. She's a youth and gender equality advocate. And among other things, she's associated with a number of global bodies, including the International Youth Alliance for Family Planning, the Partnership for Maternal, Newborn and Child Health, and WHO's Youth Council. Before I step out, I just want to thank my 4 panelists and to apologize if I did not give you the time that you would have liked to have had. Over to you, Iman. All the best.
Thank you so much. Thank you so much, Chandra, for that incredibly insightful panel. Now we'll shift into our technical panel discussion where we'll explore the progress made and the areas that still require action in preventing child marriage, increasing access to contraception for adolescents, and supporting child brides and adolescent parents. It is my pleasure to moderate this next discussion and introduce our remarkable speakers who will bring such diverse and powerful experiences to this conversation. First, we have Dr. Lauren Rumble, Associate Director for Gender Equality at UNICEF, and a seasoned advocate for child and women's rights with over 15 years of experience within the UN and beyond, focusing on transforming evidence into lasting change for women and girls. Next is Dr. Khalid Siddeeg, the Regional Advisor for Child and Adolescent Health at WHO MRO, with a strong background supporting maternal and adolescent health in both country and regional contexts. Joining us as well is Dr. Mwangi Powell, the CEO of Girls Not Brides, and a longtime leader in global public health with a special focus on gender equity and ending harmful practices like child marriage and FGM. And finally, we're honored to have Ivannia Artola, FP2030 Youth Focal Point for Honduras. She's a dynamic 19-year-old youth activist deeply engaged in SRHR and HIV advocacy from the local to global level, and a powerful voice for young people in decision-making spaces. Thank you all so much for joining us today. It's truly an honor to have your voices in this space. I'll have 2 main questions that I'll invite each of you to reflect on. So please feel free to be concise. We'll aim for about 2 minutes per person per question. And my first question is, what progress have you seen in your work when it comes to preventing child marriage, increasing access and uptake of contraception among adolescents, and supporting child brides and adolescent parents? And where do you see the most urgent gaps that still needs to be addressed? I'll begin with Lauren, then Khalid, followed by Faith, and finally Ivannia. Lauren, the floor is yours.
Thank you so much, Imani. What a great pleasure and honor it is to be here today with such a fantastic turnout of participants from around the world and such a courageous celebration of evidence-based guidelines from the WHO. Truly grateful to be here and looking forward to my fellow panelists. I want to talk about 3 things today. One is a sense of urgency. We've heard from all the speakers about the scale of the interrelated problems of child marriage and adolescent pregnancy. Both are causes and consequences of each other, and both are affecting millions of girls. And whilst everybody, and the data is very clear on this, have pointed to positive trends in decline in both of those challenges, child marriage and adolescent pregnancy, the pace of that decline is not fast enough. Not only are we not going to meet our Sustainable Development Goals of 2030, but we are going to leave millions of girls behind in rebuilding the future that they so hope for and are so optimistic about. Girls are economic drivers of change. They are powerful agents. We know the evidence is robust in this regard. We know that when we invest in girls, there are multiplier effects. Specifically, when we invest in preventing child marriage, We know that girls then really invest back into their economies. They're able to enter the labor market. They're able to, should they choose to, have children. Those children are better educated, more likely to be healthy with a positive nutrition status, therefore saving ministries of health budgets. And then, of course, being able to go to school. So we just open up so many doors when we are able to remove these barriers for girls. And when we very deliberately, it's great to hear from Sophie at SIF, invest in scale in girls. What are a couple of those investments? So my second point is about evidence-based solutions that must move now from project basis to nationally owned, co-funded by domestic governments, as well as large players like the international financial institutions, to really get that outcome effect for populations at scale. What are those evidence-based solutions? I'll just talk about a couple. One is frontline services that girls can easily access in their communities. Community health workers, which we know are largely women, over 70% of the health workforce in communities is women, underpaid volunteers, but hard at work. When those community health and nutrition workers are formalized, recognized in the system, they do a fantastic job, not only of saving girls' lives, but actually preventing harms like child marriage. We know this from Ethiopia and many other countries in the wings. Those frontline workers need to be paid, supported, trained, and have a trajectory of professional growth. The second is the kinds of community-based programs Pascale talked about, enabling community environments. No better when there is community-based programs of change with young people at the heart. Rupantaran in Nepal, actually funded by the government with support from the development community, centered on initially preventing child marriage and now is about equipping girls with financial skills, literacy, and more, has expanded from 50 to 100 municipalities. It's benefiting 200,000 girls, and it's carefully costed for out-of-school girls and in-school girls, with boys and men participating actively as well. A phenomenal program, so cost-effective and easy to replicate with the right kind of dedication and investment. And lastly, social protection. Unconditional cash transfers, simply put resources in girls' hands. They need to be able to make choices. I saw in Tanzania myself how eager girl mothers are to go back to school if they're just given the opportunity. And they need simple things like bus fares, bicycles, lunch money, some care at home to help provide for their children and their families so that they can get out under this overwhelming mantle of childcare, domestic responsibility, and all the norms that hold girls back. So lastly, in conclusion, my third point is investing in girls makes so much sense. It's their right. It's an economic imperative. As governments drown under fiscal constraints, as the world looks increasingly dark for gender equality and rights, we can pierce that darkness with the bright lights of girls themselves and our determination behind it. Thank you so much.
Beautiful. Thank you so much, Lauren, for that powerful reflection on progress and persistence. Khalid, over to you.
Thank you, Iman, and I join colleagues in thanking all those who were behind this great efforts. And I had the privilege also and the honor to be part of the steering committee of these guidelines. Yeah, just without further ado, to make use of the time, I will be talking from the Eastern Mediterranean perspective mainly. We have made recognized progress in the region in terms of reducing both early marriage and also in overall reducing adolescent childbearing. So the trend is going down, although it is going down in a slow manner, but it is going down. But we have still issues with the equities, as it was mentioned by other colleagues, and also as we have seen from Sheri's presentation and Chandra's presentation from other regions, they are facing the same issues. We have some countries where we have almost more than 1/3 of girls that got married before they reach 18 years of age. And in terms of childbearing, in terms of adolescent fertility, that figure even rise to, we have in some countries we have 1 in each 10 girls, they have also got pregnant before reaching the age of 18. So the situation is has been improved, but there are so many challenges. I will get very quickly into three major challenges that we are facing in the region. And as you all know, the Eastern Mediterranean region, we have so many countries that are affected by conflicts and humanitarian settings. So this is one of the main challenges and barriers that we have. We have so many fragile and conflict affected countries in the region that are facing huge issues with child marriage and also with adolescent pregnancies. And we know that is compounded by displacement, by poverty, and both they push families to marry off their daughters as a coping mechanism. This is well documented in humanitarian settings and causing those huge spikes in child marriages because of this. We have an example of the Syrian refugees at the beginning of the war in Syria, where the rate goes like 3 to 4 times higher. The rate of early marriage goes 3 to 4 times higher than the pre-conflict levels. Another issue, which is not only characteristic for our region, but it is clearly recognized in the region, that the issue of social and cultural barriers. The adolescents in the region, they are facing persistent barriers in terms of accessing services, accessing contraceptives. In many settings, they require parental or spousal consent in order to obtain and receive services, with social stigma that is surrounding these areas. And the last point I wanted to touch is that the gap that we are having in terms of between addressing the needs of girls who are already child brides or already adolescent mothers. So we are not doing well in terms of addressing and providing the services and interventions to this group of people. So they need this targeted support, which is continuation of education together with life skills training and learnings. And this package together with the health package, we believe that we need to do more. These are just, I have highlighted few challenges and gaps and the overall progress among others. But back to you, Iman. So, thank you so much.
Thank you so much, Dr. Siddeeg, for sharing your experience in the Eastern Mediterranean region. Faith, would love to hear your thoughts next.
Thank you so much. And I also want to echo my colleagues and partners and everybody who's spoken this morning, but also first of all to congratulate the World Health Organization, WHO, for amazing guidelines. Even just a glimpse of them they're amazing, they are needed. And I completely agree with Pascale that they are not guidelines, they're actually lifelines. When girls are facing pregnancy, teenage early marriage, I think really girls are losing their lives. So they are really lifelines for girls. So as I reflect on the progress which has been made, I want to share three things. The first thing is to say that globally, we have seen a decline in child marriage. From 2010, we had 25%, which has gone down to 19% in 2020. But I echo what Sophie said, that the decline is not fast enough. It's not even, it's uneven. Many poorer households, girls are experiencing less declines than households from higher income. We are seeing concentration of decline in Southeast Asia. We've seen Latin America, declines have stalled, West and Central Africa, where we require the fastest acceleration. So we cannot really celebrate as yet, but we need to build and learn from what we have seen. We need to focus on specific populations, including married girls, divorced girls, widowed girls, and really look at girls who are in conflict and climate places where they're really struggling. We need to push back on the rights. We are seeing a lot of rollback on rights of girls and women. We need to really build resilience so that we can push back. We know that progress, what we have seen, is not enough. There is also quite a significant amount of unfinished business. We still need to accelerate coordination, how we work together. We need to learn more from each other and use some of these guidelines to really spearhead and strengthen the work we do already. I'm excited to see the level of evidence from child marriage work, because it just shows that we know more now, and we should use what we know now to accelerate the work we do. We need to better understand how we work with gender, social norms, and how they play a role at individual, community, and institutional level, because when once we know the critical pathways for change, we can respond better to child marriage. But what do we need to do more? We need to sharpen our focus. We need to look at not only addressing the needs of addressing girls, but also their rights. I like what our first colleague talked about, investing in girls. When girls have money on their hands, they are able to make decisions which really best suit them. But we cannot forget the girls who are already divorced, and I talked about that. We need to advance progress at all levels. It's important that we increase education, and it's so good that I've seen the guidelines really reaffirming the need for secondary education. But what we need more is include comprehensive sexuality education in schools. We need to also strengthen income-generating opportunities and employment opportunities for girls, so that as they transition into adulthood, we are really creating a pathway to promote the rights of girls and to advance gender equality. We cannot also be blind to some of the rollbacks we are seeing in funding. I think that is something we need to be aware of. We have seen rollback from the US, we have seen the European donors and others really pulling back their resources. So this is a time for us to continue to advocate even more greater, so that we can increase the resources needed and commitment for girls. And finally, and I really reinforce what Sophie said, that we need to work faster, we need to work together, we need to collaborate more, learn from each other. This is not the time for silo working, and I feel that these guidelines provide a great platform for integration, for us working together and learning what we can do together across different sectors. And I'm really, really excited to see these guidelines. There's so much we can say, but I know time is of the essence here, so I'll stop there. But if there's an opportunity to come back, I have a little bit more. But thank you so much.
Thank you so much. Thank you so much, Faith. I appreciate those insights, especially a reminder that ending child marriage is not just a goal, but a matter of justice and equity. Ivannia, would love to hear your perspective.
No sé si me ven. ¿Me ven? ¿Sí me ven? Sí, ¿verdad?
Yes, we can see you.
Sí, por favor.
Ante todo, gracias por el espacio y prosigo. En América Latina y el Caribe hemos sido testigos de avances en la prevención del matrimonio infantil. Por ejemplo, gracias a la aprobación de la Ley 2447 del 2025 en Colombia, se eliminó el matrimonio infantil en las uniones tempranas en el país. Sin embargo, aún queda un largo camino por recorrer. Según datos de UNICEF, aproximadamente 1 de cada 4 niñas en la región se casa antes de los 18 años. Esta práctica limita su desarrollo personal y profesional. Aunque en algunos países se han reducido las tasas de matrimonio infantil, muchas adolescentes todavía no tienen el acceso adecuado a anticonceptivos o servicios de salud que sean amigables para ellas. Adicionalmente, según la OPS, el uso de anticonceptivos entre adolescentes en América Latina es más bajo en comparación con otras regiones, con un 30% de adolescentes entre 15 y 19 años sin un acceso adecuado a métodos anticonceptivos. ¿Qué podríamos hacer? Es imperativo que las políticas públicas se ajusten a las necesidades reales de estas niñas y adolescentes, garantizando que no solo existan leyes que protejan sus derechos, sino que también servicios accesibles y de calidad en salud sexual y reproductiva. Además, debemos seguir impulsando programas educativos sobre derechos sexuales y reproductivos para que las adolescentes puedan comprender sus opciones y tomar decisiones informadas según sus necesidades. Y eso sería todo. Muchas gracias.
Thank you so much, Ivannia. Your voice reminds us exactly why youth leadership must be more than symbolic. It has to be built into every level of our work. Now let's move on to our second and final question for this round. Very briefly, what is your primary focus or area of work when it comes to adolescent health and rights? And what do you see as the added value of the new WHO guideline in advancing your goals? This time I'll switch things up and I'll begin with Ivannia, followed by Faith, then Khalid, and finally Lauren. Ivannia, please go ahead.
A ver, prendo de nuevo. Uno de mis principales enfoques se centra en fortalecer la participación juvenil y mejorar el acceso a servicios de salud sexual y reproductiva para adolescentes desde FP2030 como un punto focal de juventudes en el país. Estamos brindando acompañamiento técnico a través de un sistema de monitoreo que permite al gobierno de Honduras avanzar en su compromiso nacional de cara a 2030, Honduras se proyecta hacia un futuro en el que las mujeres adultas y adolescentes tengan la libertad, los recursos y la capacidad de tomar decisiones informadas sobre su salud sexual y reproductiva, decidir si desean ser madres, cuándo y cuántas veces, y hacerlo desde una base de equidad y derechos. Este enfoque, alineado con las directrices de la OMS, es esencial para garantizar una vida digna, saludable, libre de violencias para las niñas y adolescentes en el país. En este caso, la directriz de la OMS sobre la salud sexual y reproductiva tiene un valor añadido crucial, ya que proporciona un marco global coherente para abordar las necesidades de salud sexual y reproductiva de todas las personas, con especial atención en adolescentes y niñas. Esta directriz es un referente técnico que ayuda a los países a fortalecer sus políticas nacionales e identificar brechas en el acceso a servicios y garantizar que los derechos sexuales y reproductivos se integran plenamente en las estrategias de desarrollo sostenible. En el caso de América Latina y el Caribe, su implementación es clave para enfrentar desafíos persistentes como el matrimonio infantil, el embarazo adolescente y la baja utilización de anticonceptivos entre jóvenes. Muchas gracias.
Thank you so much, Ivannia. Your words so clearly show how the guideline can be a real tool for action in the hands of young advocates. Faith, over to you.
Thank you so much. I can't start the video, so I hope somebody else can do it. I work for Girls Not Brides, the global partnership to end child marriage, and we work with over 1,400 organizations across 100 countries working to end child marriage. So in terms of our work, our focus is really ending child marriage, and we are, yeah, 1 minute. Yeah. Thank you. Somebody is telling me to start the video half. Thank you. Yeah, so in terms of our work, our interest is really ending child marriage, but we recognize that child marriage doesn't happen in isolation. It's part of a multi-sector approach in terms of girl education, sexual reproductive health and rights, gender equity. It's all those concepts. We cannot just look at child marriage in isolation. So that's why these guidelines for us are exciting, because not only do they bring evidence where it's strong in terms of what needs to happen or what has happened in terms of ending child marriage, and this gives us our program confidence in how we do our programming. So that for me is one value added on these guidelines. The second one is that it brings the powerful agenda on how we can work collaboratively, how we can work through an integrated framework. I really love the analytical framework on how we can start the process of integrating some of the work or some of the evidence which is within these guidelines. So that for me is a great added value, but also it gives us ammunition. I like when I go to speak to governments to be able to show them the evidence which is there on what works, especially when we look at some of the gender-based values around education. We have said that we want to ensure girls complete up to 12 years of quality education, and there is evidence to prove that works. That for me is ammunition to negotiate and to advocate with government as partners in this work. There is also clarity, and I was excited to see how much evidence there is around child marriage. What that tells me is that we are learning and we are understanding what works and what we need to do in order to do better to accelerate the change we are all seeking for. We also want to look at how we can be able to provide some frameworks across countries. I was excited to see that the monitoring and evaluation framework is very strong, because that is important, because then we can measure how we are doing, what we are doing, and how we are achieving the results. I think this is guideline for me is also a call to action for governments who we think are critical partners in this work. We recognize while the global community is here, everybody, all 500 of us in this webinar and many more who we represent, we are here and we embrace and endorse these guidelines, but we need our partners, the government, so that they can work with us. So this is a valuable tool for our advocacy, for our implementation, and for our service provision. So it's a welcome addition to that. It's a tool in our box. It's such a welcome addition to the things we have. Thank you.
Thank you so much, Faith. That was such a strong reminder of how guidelines like this help us challenge the status quo. Khalid, would love to hear your thoughts next.
Thank you, Iman. For us in the WHO, Regional Office for the Eastern Mediterranean, we are advocating for a holistic and comprehensive approach for adolescent health priorities, based mainly on, as also mentioned earlier by Sheri, based mainly on the global accelerated actions for the health of adolescents, to address adolescent sexual and reproductive health issues within this overall umbrella of adolescent priorities. In fact, this approach proved to alleviate lots of sensitivities that we are facing when it comes to adolescent sexual and reproductive health in our region. And within that overall umbrella, we are prioritizing 4 areas of work. The first one is the continuous work on advocating for ending early child marriage through policies, laws, and community engagement. In the region, we have been working with partners from different sectors and with also our member states to end child marriage through advocating for enforcement of laws that are prohibiting marriage. As I mentioned, we have so many countries with laws that are prohibiting marriage under 18 years of old, but unfortunately that is not well enforced in many settings. And also by engaging community and faith leaders into changing the social norms. We believe the new guidelines or the updated WHO guidelines reinforces the actions that are needed by urging legal reforms and community engagement to prevent child marriage. The second point that we are also prioritizing is the work on improving adolescent services uptake. Our primary focus in the region is expanding the adolescent sexual and reproductive health services as a component of this comprehensive package of adolescent health. And we are trying to help countries to build the capacities of the care providers and also to improve the care environment at primary healthcare level and also at other levels of care by making sure that contraceptive and other services that are necessary are well provided. We have very interesting examples from countries that you might think are difficult countries like Afghanistan, where we have adapted the package to the local context and we have trained the care providers. So this aligns with the guidelines emphasis on ensuring adolescents receiving high quality and right-based services. The third area, which is linked to the challenge that we mentioned earlier, is addressing adolescents' needs during emergencies and in humanitarian settings. This is another important area, and that means for us that we need to make sure that the needs of adolescents are well represented in preparedness and response plans, and also integrating the health of the adolescent sexual and reproductive health into emergency health responses. This is including services like contraceptives, menstrual hygiene, care for sexual violence. These are all being part of this relief efforts. We have done a lot in terms of capacity building for our countries and also the partners, the NGOs that are working in the field in terms of training in adolescent sexual and reproductive health. We have done a lot in with the support of Dr. Chandra when he was in WHO HQ, and we continue doing that with others, targeting many countries in our region. The last point that of priority for us is keeping girls in schools and providing education, including all what we talked about, sexuality and reproductive education. And sometimes we have seen countries in the region, they are giving different names to it, but the idea that the contents is addressing the girls' need. This highlights the area of multi-sectoral collaboration because it is central to the current efforts that we are doing. We are working with our health partners or ministries of health together with the education sectors to keep girls in schools and also to make sure that we have age-appropriate education interventions. We believe the global standards of health promoting in schools and the WHO guidelines of school health services, both are new, relatively new guidelines and standards. They were launched in the past 2-3 years. They are representing good and excellent platforms in this regard. And we believe that the updated guidelines adds lots of weight to these strategies because it highlights that all girls to complete their secondary education and they receive the appropriate education messages that they are needing to make sure that they are making informed decisions. So we believe that by doing so and having sensitivity to those social issues, that both girls and boys, we can help them to make good decisions and to reduce early marriages and early pregnancy. Thank you so much. Back to you, Iman.
Thank you so much. I appreciate those insights, Dr. Siddeeg. Lauren, I'll turn to you to close us out.
Thank you, Imani. What a pleasure it is to close out with you. Thank you for your leadership and great facilitation. Maybe I will be really short because I agreed with what everybody said. One thing to highlight is these guidelines formalize what girls have been telling us for decades. Adolescent girls care about other adolescent girls who are married and pregnant and who are sidelined and invisible from the mainstream. They're fighting for girls in Sierra Leone to go back to school after they've had children, for childcare facilities to be available in communities so girls can get jobs and have more decision-making power and income. They're fighting for girls to be married girls and parenting girls to be reflected in service guidelines in Nigeria. So here we are at long last. And as a community, we should ask a tough question about why so long have we taken to make such a priority for girls and boys actually into the public health mainframe. Now we can take this tool, as Faith called it, and really start to transform lives, to turn that urgency. No longer should we be seeing pregnant and adolescent mothers in long queues for maternal health services. They should be at the absolute front. And of course, they should be back in at school. And of course, they should have equal and non-judgmental access to services. So thank you very much to WHO for breaking the silence. And to all of us, then, it behooves us to take those girls' wishes and hopes forward.
Thank you so much, Lawrence. You really brought us all together. And thank you to our amazing panelists for sharing your insights, passion, and vision. This conversation reminds us that addressing adolescent health and rights is both urgent and deeply interconnected. And with the launch of these new WHO guidelines, we have an important opportunity as well to move from intention to impact. So thank you all again, and I'll pass it over to Nandita for the next segment.
Thank you, Iman, and thank you to all the panelists and to the facilitation from both you, Chandra, and you, Iman. I'm now going to turn it over to our final speaker for some closing remarks. Anshu Mohan, welcome. Anshu is a Senior Strategic Advisor for SRHR and Adolescent Well-being at PMNCH. Anshu, you have the floor. Welcome.
Thank you, Nandita. It's a very hard and a very tough act to follow after all that has been said. You know, this room has been so rich, but I nonetheless want to take a moment, take a beat to highlight some of the things that have been said. And of course, huge thanks to the panelists for their expertise and their insights, and huge congratulations to WHO and partners on the launch of the guidelines. As I listened to this conversation today, there were several thoughts that flooded across my mind, but one kind of stuck, and that was of dismay. And I'll explain why. Adolescent girls are our future leaders, innovators, and change makers. Yet the world has been and continues to be a dangerous place for them to survive and thrive. And as has been flagged many times by many different speakers today, every year, 20 million adolescent girls in low and middle income countries become pregnant. Globally, 1 in 5 girls is formally married or in an informal union before the age of 18. Now, these are the girls who have been denied the education, denied childhood, denied choices. How fair is that? But I also pause and say, this is not to say that there hasn't been progress. We've noted throughout this conversation that indeed there has been progress. And globally, the adolescent birth rate has declined. But this progress has not reached everyone. Inequities by income, education, geography persist. And with the growing political pushback on rights, many girls remain invisible and left behind. To achieve our goals and ensure that these inequities do not persist, our vision and our mission must be collective. Khalid, my old friend and colleague, said multi-sectoral approach underpinned by principles of holistic well-being are central to achieving results. The updated guidelines launched today are an important part in moving the needle and a key to unlocking huge resource. Last year, PMNCH launched the Adolescent Well-being Investment Case. And the headline of the investment case is the cost of inaction on adolescent well-being. The world, collectively, all of us, this community stands to lose $110 trillion between now and 2050. This equals to roughly about $4 billion a year which we can't afford to lose. This world can't afford to lose. Equally, returns on investments are staggering. For every dollar invested in reducing child marriage, we get almost $27 in return. For every dollar invested in keeping girls in school and keeping them and giving them education, we get $29. Both are drivers of reducing adolescent pregnancies. My friends, this is a powerful gathering, capable of driving immense change as well. And for all of you, I have 4 calls to action. Act, as has been said many times before, we must move beyond words to action. Guidelines must be translated into policies, and policies into real programs with budget, with trained health workforce, and a very strong monitoring system. To be an ally, adolescents and youth are co-owners and co-drivers of this agenda. We have to work with them to work for them. Meaningful adolescent and youth engagement must be the norm, not the exception. Be accountable. Progress does not happen overnight. It must be demanded. It must be measured and shared through indicators, indices, and national tracking mechanisms to ensure that commitments actually translate into action and impact. Finally, ask the uncomfortable question. Are we doing enough? Are we reaching the most vulnerable? We have to take a beat. We have to ask those questions. The return on investing in adolescents, girls, is profound. The world needs their power, their vision, their leadership. And it is our duty, our responsibility to dismantle that barrier, amplify the voices, and back them with everything we have got. Wearing my very new and shiny WHO Southeast Asia region hat, I promise to ensure an early and efficient rollout of the guidelines in the region. I encourage colleagues and champions from other regions to put their very powerful shoulder to the wheel. The guideline is a tool for sensitization and transformation, one which will impact millions of lives for a world where no girl is left behind because she grew up too fast. Thank you very much for this wonderful conversation, and huge congratulations to the team that led on this. Chandra, Sheri, well done, really well done. Thank you.
Thank you, Anshu, for your powerful closing remarks. And again, just one last thank you to the entire team for your incredible work, and to our participants for your active engagement in today's session. We've been sharing lots of resources in the links. Please do stay engaged as we continue the implementation of this very important guideline. Finally, just a quick thank you to our interpretation team for making this session available in French and Spanish as well. Thank you, everybody. Wishing you a very lovely rest of your day, and hope to meet again as we move this important guideline and adolescent sexual reproductive health agenda forward. Thank you. Bye-bye.
Thank you.
Thank you, everyone. Goodbye.
You and bye.
Thank you.